Welcome to Dilemmas in Dementia, a series which explores real-world challenges in dementia practice and strategies to help address these issues. In this episode, Dr. Kyra O'Brien, Assistant Professor of Neurology at the Hospital of the University of Pennsylvania, discusses modifiable barriers to performing cognitive evaluations in primary care. Based on the results of the study, Clinician-Reported factors influencing performance of cognitive evaluations in primary care. Welcome, Dr. O'Brien. Could you please explain the background of this study? What prompted the study and why is it important?
This work really all began pre-COVID around 2019 and began as a care improvement initiative at Penn Medicine. So we were trying to solve the problem of getting too many referrals to specialty care that we couldn't see in a timely manner. And so the question was, what can we do in primary care to kind of triage these patients, get an initial evaluation done? And what I found was we didn't really have a good way of approaching the problem. Like, all the people in the room were neurologists and did not have any primary care representation. And so I wanted to go about this in a more systematic way with, the voices of primary care. COVID happened, so it put a bit of a pause on things. But then with funding from AAN, actually, I undertook this study. So we interviewed several primary care clinicians at Penn to figure out what the pain points were in doing cognitive evaluations. And we've moved on to the second part of that study, which is presenting all this data from the interviews to a group of stakeholders, including neurology, primary care clinicians, and clinical operations specialists, to then develop an intervention from this. So really the purpose was to conduct a needs assessment at Penn and then address those problems.
Please provide an overview of the study methods. How did you structure the interviews with primary care physicians, and how are these interviews analyzed?
The way we approached this study was we wanted the clinicians to sort of be in the mindset of evaluating a patient with cognitive impairment. So the interview structure was set up. So we initially asked them just general characteristics about their practice, how many patients with a memory complaint they see on average, how comfortable they were with a cognitive evaluation. And then we used a implementation science framework called the Consolidated Framework for Implementation Research, or CFIR, to structure the evaluation. So within CFIR, there's different domains, including the individual, which in this case would be the primary care clinician, the outer setting, which can be defined in different ways, but we defined it as the health system and sort of the local policy context. And the inner setting, which is your primary care clinic, and then the innovation. So in this case, the innovation is doing a cognitive assessment. So we asked them about each of those areas and if there were specific things within them that made it easier to do the evaluation or more challenging. And then we thought it might be helpful for them to actually review one of their own patient cases and talk us through that clinical decision making. And it really helped us understand, in an ideal world, I would have done this, but because of these reasons, I didn't. And so that method is called chart stimulated recall. And so we did that for every clinician that we interviewed. And then afterwards, we did thematic analysis, pulling out themes that answered our research questions. And it was structured around the CFIR domains. So we identified the most pertinent barriers and facilitators within the CFIR domains.
What were the results of the study?
So as you can imagine, there were several different barriers that arose. So starting with the clinicians, they really felt like they lacked the confidence to do these evaluations. A lot of them didn't have any training or hadn't had training since residency in doing a cognitive assessment, like a mini mental or a MOCA. There was also attitudes, beliefs, stigma around giving a diagnosis of dementia or Alzheimer's disease. Some of them felt like it would just cause needless anxiety. They felt like there wasn't anything they could do for the patient, so why would they evaluate for it? But on the other hand, some of the facilitators, I feel like, where some clinicians had very personal experiences, like with a family member with dementia, and though they expressed the same limitations, like not having the same resources, they felt like they had a responsibility to do these evaluations. I would say the overwhelming majority of them felt like it was the responsibility of the primary care clinician to do that initial evaluation. And so I feel like we can leverage that and then address all the systemic barriers that they identified. So in the clinic, there's time pressures. They have 10 to 15 minute visits. and it takes that long to do a MOCA, so that's impossible. They have staffing shortages. In terms of the overall health system, they said it's not really a priority, dementia care. We have all these metrics for cancer screening and hypertension and diabetes management, but there's nothing for dementia, so it seems like it's a lower priority. And then in terms of connectedness to other resources within the health system, they felt like there was a lack of social work support. So even if they have a patient who they diagnose with dementia, they wouldn't be able to get them connected with what they need. Access to a dementia specialist was something that they all said would be great, but we have a very long wait list at the Penn Memory Center. And so they said if we could consult with the specialist, not necessarily have the patient see them, but just get their advice, maybe that would help us do a little more for them.
What were some of the key takeaways from this study? What did you learn from conducting these interviews?
So I feel like a lot of interventions in the literature around improving cognitive evaluations in primary care have focused on educating the primary care provider. And while for some people that might help, like that's the bare minimum of what's needed, they're facing a lot of systemic issues that even if they know how to do the evaluation, they still can't do it. So my main takeaway is it's going to take a multi-pronged intervention to help this situation. So you do need the education, you need continued training to address staff turnover, updates in the field. You need readily accessible clinical decision support, so it's a constant reminder of what the right thing to do is, and then it just becomes second nature. I didn't mention this, but a large barrier were patient-related factors, so cultural barriers, language barriers, and so helping them navigate that and figure out what to do with those patients. And then, of course, there's the patients who have access issues, so like giving them the community supports they need to make it to these appointments and get the assessment done. So we're looking at essentially building patient supports, primary care provider supports, and education, and connecting primary care with neurology as part of this intervention that we're designing.
What are the future directions? What would you say is needed going forward regarding primary care physician training?
For the training needs, I think globally we need to start with sort of education around what dementia is, what mild cognitive impairment is, how that differs from Alzheimer's disease and related dementias. And then we need to educate them more on what you can actually do for the patient to combat that stigma, that belief that you can't do anything for them. And then especially now with the anti-amyloid therapies and many other drugs I'm sure coming down the pipeline, they need to be kept up to date on those advances, and would help if they had some patient interaction in that education, because patients can really advocate for themselves and convince doctors that, yeah, this is the right thing to do. So I think that would be helpful. And then just generally, as we're starting to implement these new pathways, we'll have to provide training for our clinicians to follow that pathway and know what the next steps are. And as I mentioned before, like the clinical decision supports will be a part of that. So in terms of the future directions of this, we're creating that training. We are designing a cognitive testing service that's based within primary care and driven by advanced practice providers, so that primary care provider can refer to them to get the mini-mental or the MOCA done, and then they'll have that information before the cognitive visit so they can spend more time focused on the history and next steps. We've got patient reminder things, scheduling assistance with social work that we're trying to work out, implementing e-consults or interprofessional consults, so primary care has more access to neurology and geriatrics for consultation.
Thank you to Dr. O'Brien for sharing her knowledge with our listeners in this episode of Dilemmas in Dementia. And thanks to you, our listeners. Be sure to visit theneurologyhub.com for more podcasts in the field of neurology.